All right, well, hopefully the delay was worth it. And hopefully I'll answer the, what's this? We're running off of that. Okay, thank you. The young lady that had a very pertinent question. So supply chain, God, do we not, we almost hate using that word, don't we? But is it a blessing or a curse, and innovative ways to approach to reducing cost? These are my disclosures. I'm old, so I've helped everybody. Dealing with the competition. This isn't about supply chain. This is about you. You know, in the wilderness, you have people fighting over food. It's amazing in our hospitals. We just oftentimes don't have good partnership between our administration and our physicians. But the reality of it is we have to work together because the country's broke. Internalize that just for a second. The country's broke. And now we'll have the right discussion. So everybody wants to be competitive, right? Everybody goes, you know, the young guys, how do I build my practice? Well, slowly going away is the referral-based security. Your institutions think they come to you because of them, not them to you. You know, the mail's thrown away, they don't even read it. Letters are e-filed, so they don't read it. Dinners aren't attended or they're illegal. Gifts are illegal. And separating yourself by being the best. Have you ever heard of a marketing hospital in the United States that isn't internationally known nowadays? What's not going away or going to come to you is the first of the 3 A's, and that's access. There needs to be an economic advantage, so you have to really internalize value care. The patient experience, and then, without a doubt, convenience is going to be important. You know, healthcare has undergone a tremendous explosion, and it's going to continue to innovate even faster than any of us have experienced in our careers. But it's really going to be important because all those innovations cost a lot of money. And hospitals see upfront costs, where what we really need is for the payers to see what's really going on. I think you've seen this multiple times in different talks, but we spend a lot more in the United States per capita than almost any country in the world. Now, we do most of the research as well, but it's a big deal because this is being one of the big things that are breaking our country. If you look at 1942, we actually dug this up. One of my partners, Raghu Klori, I don't know where he got this. I think he saw it at an auction. But look at the things that are kind of interesting. An operating room fee was $5. And look what is now a federal crime, professional discount, $885. And this is what things cost back then. A car, about $1,100. Gasoline was 19 cents a gallon. You could get the, you know, house was $6,900. We've changed a little bit. And if if food had changed as much as medical inflation, a dozen eggs would be $85. A pound of bananas would be $17. A pound of bacon would be $129. A pound of coffee, $68. So everybody take that and internalize that because we're way too expensive. And what of the current system, you know who that is pushing that cart? The cart on that is us. The ones pushing it are our grandkids. Internalize that. We can't be so selfish that we're going to continue to push this on them. So at 20% of GDP is not sustainable. Now, we always act like we're holier than thou as docs, but here's what I also want you to internalize. If any of these things hit for you, change, or go sell cars, unindicated procedures, playing for restenosis with non-drug-based technology. I was at a major surgical conference when they showed about a 15 to 20 centimeter stenosis that was treated. It looked great after a plain balloon angioplasty. And over 75% of that room said they'd leave it alone. That's plain for restenosis. Doing the highest reimbursed procedure when it's not needed. Unnecessary testing. Dealing with procedures instead of prognosis, i.e. TAVR in the demented. Deals under the table related to device usage, and et cetera, et cetera, et cetera. We have to be the higher force. And it's going to come on us if we don't take care of it. The payers are collecting data on each one of us. They know what we're doing. They know how much we're costing. And given that data, the insurance companies are going to start to dictate the procedure or surgeon with the lowest revision rate. So it'll be an episode of care, and who's most expensive for an episode of care. So we have to change this battleship that we've been on because it's way too out of control. Supply chain has multiple functions. They look at demand, the versatility of the integrated partnerships, procurement, inventory control. But what they're the ones that get the devices. And they have to be educated, as does the hospital, that upfront cost is not everything, it's episodic care. But their realities are they're historically separated from reimbursement. They don't know what a pass-through code is. They don't know how much you're getting reimbursed for that atherectomy device. They just know it costs a lot. They really don't have insight into the important stuff. All the pacemakers are the same. It's an electric box in your chest that keeps your heart going. Promotions are driven by cost savings. As docs, we've all experienced this. What happens to hospital administration? It's a 2.5-year rule. In 2.5 years, I want promoted or I'm gone. And how do you get promoted in 2.5 years? You cut. Negotiation is a big part of their job. Little insight into research and relationships, as the speakers have talked about, and little insight into advancements, and they have no idea about episodic care right now, but they have to be brought into that. There's upsides, though. They can make you more competitive with the payers. There's less emotion. So where that guy you really like that helped you out in the middle of the night with your procedure, it takes that emotion out of trying to bail him out and throwing him a bone. But less emotion with help with value analysis. They can take the physicians out of awkward moments. They can help. I've got a minute left, sorry. They can do a lot of good things for us, but they certainly can decrease waste of expiring devices. So innovative approaches. Focus on the episode of care. There's power in numbers and consensus. Our Vascular Institute has over 45 members. We help drive decisions. And if you do that without really being self-serving, you really can do a really good job. Focus on commodity. Give them that one. Don't focus on the petty. Focus on the advances. Seek input when you need to be and be inclusive. Provide feedback as you can. This is one of the things we have at a quarterly basis. This is our Accelerate purchasing. We see, are we staying good on the controlled commodity products? And if not, we go talk to the docs that are way out of line, because there's usually a reason behind it. But in summary, there is a non-sustainable cost of today's healthcare in the U.S. We physicians don't play a major role in revising this. The patients are going to be hurt, and I think that's why we're here. Working to develop insightful supply chain will be the best for everyone and unify across specialty lines. Pick your battles to win your, maybe lose a battle, but win the war with episodes of care costs. Thank you very much.